Okay, hi everybody. Welcome back to the CBSPD Hot Topics virtual conference hosted by Beyond Clean and sponsored by 3M. A full day dedicated to exploring the hottest topics in the sterile processing industry. If you're just joining us, I'm Brett Norton, your co-host for the day. Our next speaker is William Filipponi, Director of Sterile Processing at North Kansas City Hospital. Throughout his career, William has worked in all phases of sterile processing, from frontline technician to director. Over the last 29 years, William has worked to create a safer environment for the patients and staff. Today, William is going to discuss the who, what, where, and whys of handling surgical instruments in the OR suite. He will discuss the importance of implementing a point-of-use pre-treatment program, offer tips for streamlining this process, as well as debunk common myths surrounding pre-treatment. Get ready to advocate for pre-treatment in your OR. Let's welcome William.
Thanks, Brett. I appreciate it. Hello, everybody. Once again, I'm William. Wanted to thank Brett for the introduction and the Beyond Clean team for having me on today. Wanted to go over a successful point-of-use treatment program. As stated, I'm from the North Kansas City Hospital. I'm the Director of Sterile Processing. I've been in sterile processing for the past 29 years, and this seems like a topic that comes up all the time when we're discussing proper treatment of instrumentation. So today, obviously, we're going to go over the point-of-use standards, understand the formation of biofilm, what are the proper ways instruments should be returned to sterile processing, and how do we accomplish this and sustain a point-of-use treatment program? Everyone agrees. When we look at the standards that surround the operating room and sterile processing, we see that pretty much every organization out there says the same things. We look at the Joint Commission, and the Joint Commission requires that gross soil be removed from instrumentation. AORN, the Association of Operating Room Nurses, their recommendation is that instruments must be cleaned and decontaminated as soon as possible after use. I always like to add this part in when we're talking about the pre-treatment, and that's when an instrument is composed of more than one piece, we need to make sure that that instrument is open and disassembled. We want to do that according to the IFU. And we want to arrange it in the tray in a manner that allows contact of the cleaning solutions with all surfaces of these instruments. The Association of Surgical Technologists obviously are saying the same thing. Cleaning of the instrument should begin during the surgical procedure to prevent the drying of blood, soil, and debris on the surface and within lumens. AMI, gross soil must be removed at the point of use. Prior to transport, instruments will be prepared in a way such as to prevent organic soils from drying. So when we look at why we want to do all of those things, I think the one word that we see there that comes popping out is gross soil. Gross soil is the word that we kind of look for the definition that we have trouble finding. When you look at what one person considers gross soil, someone else may consider something completely different. So I did a lot of research on the word, gross soil. And when we look at that word, break it down to soil, obviously is something that spoils or pollutes. But when we look at the definition of the word gross, the one thing that I could find was visible without the aid of a microscope. And when we think about how instrumentation comes back from the OR, if we're asking them to remove gross soil, that means that they remove everything that can be seen with the naked eye. That's a big step sometimes for some ORs to accomplish. Why do we need to remove those things, right? That's the important thing, right? When we look at, why we're removing gross soil at the point of use, and that's to limit the formation of biofilm. When we talk about biofilm, we talk about that collection of microorganisms that kind of attach to a surface and become very, very difficult to remove. bacteria within biofilm can be up to 1,000 times more resistant to a given agent than one bacteria alone. And the other stat that I found that was pretty amazing was that 65% of all microbial infections are due to biofilms. Biofilms protect the microorganisms and make it harder to be removed with regular cleaning processes. You know, when we talk about biofilms, the easiest example of that is when we look at a water bowl for our pets and that slime that kind of forms in that water bowl. That's everybody's example of a biofilm. But what we do know is that it's way easier to clean that device before they form on them. One of the things and areas that we discuss is what does it take for that biofilm to start forming? When we look at the different stages, we look at that first stage, where is that initial attachment where the bacteria starts forming on the surface and starts collecting. The second stage is that stage where it's an irreversible attachment. I always like to jump back and forth between these next two slides because I have the list here, and we have that irreversible attachment. Then you have 3 and 4 where the microbes are maturing and growing, and then you have 5 where it's dispersing. We're going to jump back to this picture where you can see these items up close. And when we look at these second, third, and fourth, and fifth, we want to break that chain of infection right there after that first one. We want to stop it before it gets to that point where we have irreversible attachment. You know, once you have irreversible attachment is where you get the point where just rinsing it with water doesn't take that microbes off of that product. Biofilm reduction, right? It's challenging because the detergents actually cannot penetrate that shell that the biofilm forms when it becomes a colony. Right? We want to clean that product as soon as possible after the use of the instrument and after initial attachment. We also want to flush lumens, including flexible scopes, at the point of use to help decrease that biofilm formation. You know, this can happen during the procedure. You know, if you have a lumened item, you know, and you have it sitting use and it's sitting it there, and you know, you want to rinse that product out of there so the biofilm doesn't start forming while you're doing the procedure. Why do we have to do this, right? Obviously, the first thing is, you know, prevent instrument damage. You know, when we have bioburden on the instruments, it can actually increase instrument damage as those instruments are used and that bioburden is left on the instrument. You know, we're rinsing off those instruments to prevent that biofilm formation. When they rinse the instruments during the procedure, it makes the instruments easier to properly clean once they reach the sterile processing, and it improves the efficacy of the sterilization process. And probably the number one reason is that it's the right thing to do for our patients, right? Our number one goal in sterile processing. So I have a few examples of some incorrect trays, right? When we look at trays that come back to sterile processing, we want to make sure that we're seeing trays that are instruments are opened, instruments are sprayed with some type of pretreatment, and that gross soil is removed from those trays. When we look at this orthopedic instrumentation, this is probably the hardest area when we look at, you know, what the OR can do in the OR room. You know, we don't want the OR staff in the OR room taking a brush and cleaning instruments in the OR suite. We want the instruments to be cleaned in the decontamination area of sterile processing, but we also do not want tissue and debris left on the instrumentation when it's being transported to sterile processing. You can see on this slide that there is a lot of instrumentation, or a lot of bioburden on the Cobra retractor that we have there. But if you look at the other instrumentation as well, as we talked about what the definition of the word gross is, we can actually see visible blood on that product. So if it's visible without the aid of a microscope, that's what we would consider gross soil. When we look at these products, these instruments in here, the acetabular reamers are probably one of the most difficult items to get rinsed out, but that is definitely one of the products that can have bioburden and biofilm form on it the quickest. The instrumentation in this tray as well, very similar. When we look at instrumentation coming back from the OR, we want to see, instrumentation that's opened, all the gross soil removed, and placed into a tray that helps the cleaning process. So if we look at this tray here, you can see that obviously there is gross soil still left on the instrumentation. The instrumentation is piled into that. When this instrumentation gets through the washer, it's obviously not going to be a very efficient process when we talk about how this instrumentation gets sent back. Very similar to those instrumentations, this instrument has been sent back to the sterile processing department with bioburden all over it. Obviously, if you look at it, you can see that there is gross soil. There's been no pre-treatment sprayed on it, so all this bioburden is dried blood. We know from what we do that when we let blood sit on an instrument and dry, it starts eating away at that passivation layer of the instrumentation and can start causing pits or issues with the first layer of that instrumentation. When we get into this tray seems to be a lot better than some of those past trays that we've seen. We can see that the instrumentation is in it. There's not much bioburden that you can see. It's been sprayed with a pre-treatment. But when we break this tray down, we look at these instruments that are down here are unopened. They are closed. We have tip protectors still on some instrumentations, and we have integrators, right? Trash in trays. Part of the pre-treatment process is to remove that trash from the trays and making sure that all the instrumentation is open. When we look at this tray here, very similar to that last tray, we can see that instrumentation is placed in the tray, but we have some of the same issues: instruments not opened and tip protectors, trash still left in those trays. And this is just another tray. You can see that with the bioburden still left on the instruments. So let's talk about why is it difficult to get this plan in place. When you look at the OR staff, they're being tasked for quick turnovers, right? That's definitely something that we deal with in our facility all the time. They have 15 minutes in some cases to turn a room over for another surgery. One of the excuses that we've heard in our facility is, if you want them done that way, you're going to actually increase the turnover time in my room. And we kind of feel like if trained properly and done during the procedure, that it really should not increase turnover time. I always relate this to when I change the tires on my car. I could get it done a lot quicker if I don't tighten the lug nuts, but obviously it wouldn't be safe for me for the next week while driving that car. We want to make it as safe as we can for our patients. Another excuse sometimes that we hear is, I thought sterile processing was supposed to clean the instruments, right? And my answer to that is, we still have to clean each and every one of the instrumentations, whether it was used or not, but pretreatment makes this so much easier, and it decreases bottlenecks in the decontamination room. If we can clean a tray in 15 minutes as opposed to 45 minutes when it comes to us, it'll make things run more efficient. And this excuse, obviously is one of my greatest nemesis. I've always sent them back like this, right? So as we work in healthcare, we know that change happens every day, and we want to improve everything that we do in our roles every day. So I have some examples of the correct trays of what we want to see and how we want to see them. And this is after pretty much a house-wide push on pretreatment of instrumentation. We rolled out a pretreatment plan for the OR at our facility and educated the whole OR team, from surg techs to facilitators, all the way through the OR, so that everybody was on the same page, everybody was speaking the same language, and then we started getting trays back correctly into the decontam room. Right? So when we look at trays that come back, we want to see trays come back that have no visible bioburden. All of the instrumentation is opened. There's no trash in the tray. Sharps are segregated, and instruments are sprayed with a pretreatment. Separate tray that actually has instrumentation that needs to be disassembled. So when that tray comes back to us in the decontam room, we see that there's no visible bioburden. Instruments are opened, and in this case, they're disassembled. We have no trash in the tray, and that instrument tray was sprayed with pre-cleanse. When we look at this tray, we can see that, same things, right? So this is as we look at these trays and the correct trays, they should all look very similar. These are trays that you can see have been wiped during the procedure. They've been sprayed with pre-cleanse or a pre-treatment. There's no trash in the tray. So what we must do? We want to keep instruments clean during this process. During the procedure, with a sponge moistened with sterile water. This is one area sometimes it can become difficult for that OR staff. When we look at that, having that pan of sterile water on your back table, some surgeons push back against that. One of the things that we've done to kind of alleviate some of that pushback from surgeons is actually present at the surgeon committee this same procedure PowerPoint that I'm presenting to you in a little bit of a shortened version, so they understand the importance of what we're asking their surgical team to do. And that's one of the ways that we've kind of helped increase our ability to increase the pre-treatment of the instruments during the procedure. We also want the staff to use sterile water to irrigate lumens during the procedure. If you have a Yankauer suction that you're using at the beginning of the procedure and it's going to sit there for 20 minutes, a half an hour before it needs to be used again, it should be irrigated with sterile water. One of the questions that I hear a lot is, well, how long does it take biofilm to form? And pretty much the only thing I can say to that is, as bacteria grows, different bacteria grows with different reasonings. Environment, moisture, temperature, light, all can affect how fast bacteria can grow. So it's better to get that process started at the point of use so it stops almost immediately and breaks that chain before you get that irreversible attachment to the surgical instruments. We want to make sure that all instruments are opened at the conclusion of the procedure, whether they are used or not. You know, when that instrumentation comes to sterile processing, we don't pick and choose to only clean the instruments that were used. We have to clean all of the instrumentation that came out of that OR room. Instruments that can be taken apart are disassembled. One of the tough areas that we had in our facility was this next one is the instrumentation will be arranged in an orderly fashion within the original set configuration to minimize the risk of instrumentation displacement. We had a issue with instrumentation being mixed. So if they opened 4 trays in an OR room, those 4 trays would all be mixed together. And what we did was we had a push to actually have the staff put those instruments back into the trays that they came out of to help reduce the time that we spent trying to search for instruments. I mean, it could be hours or even days that it would take us to find an instrument that was missing from a tray. Dispose of any indicators or tip protectors and any trash that may be in the tray. And again, like I said, we had a problem with this, so I actually put it on this presentation twice. All instruments must be placed back into the original tray in a manner that would aid contact of the pretreatment and avoid damage. So not only do we ask the OR staff to put those instruments back in a tray that they belong in, but we also ask them to try and help us avoid the damage of that instrumentation. You know, we don't want a tray full of delicate instruments with a 5-pound mallet sitting on top of them. That whole transport to the decontamination area will cause damage when we see things like that. So one of the things that, you know, as we look at how this happens, during the procedure, we talked about that. So after the procedure, we want the staff to change into clean gloves, right? And obviously, anytime you change your gloves, you want to perform hand antisepsis before donning your new gloves. We want them to spray all of the instruments generously with the pretreatment, you know, and we want to make sure that they're getting it on all sides of the instrumentation, right? So we're spraying it from the top, we're spraying it from the side, we're spraying it from the bottom almost. We want to make sure that, you know, that instrument is completely covered in that pretreatment. And then we want to ask that they clean that pretreatment can with a disinfecting wipe before they return it to the holder. Once the instrumentation is sprayed, it can be placed into a case cart and transported to the decontamination room. We want to make sure that we have that case cart labeled somehow as biohazard. There are multiple ways throughout the industry to have a label for a case cart, whether it's a magnet or a wheel or anything that can kind of denote that that tray, that case cart has biohazard material inside of it. We want to make sure that they've removed and properly disposed of any sharps and placed any sharp instruments in a separate container, right? We want to, obviously, we're here for patient safety, but we're also here for our staff safety as well. And one of the things that we noted here was we had staff that were spraying that pretreatment inside of the cart. And what that causes a whole nother issue with the cleaning of the case cart when it runs through the cart washer or when it's cleaned by hand. So when we talk about how to sustain this process, one of the things that we have happen here, we do audits at the point of use in the surgical suite. So we have leadership, staff, all doing different audits at different times during the day throughout the OR. So they're watching actually the procedures and how those instruments are handled during the procedure and after the procedure. And then we have our sterile processing staff doing spot checks in the decontamination area. We have developed, obviously, an audit for this process, but we've also developed a way to deliver feedback. So our OR has feedback forms for sterile processing, but now we've included a feedback form from sterile processing to the OR. So as we get those trays that maybe aren't done correctly, we can actually fill out that feedback form to get to the OR, so it gets to the correct person, and the education can be delivered in a timely manner to that person that maybe sent that tray back not in a correct fashion. That's the end of that. I think Brett was going to jump back on. That went a little quicker than I anticipated.
You're good, man. Sometimes this warrants a lengthy discussion because there are a lot of missteps when it comes to pretreatment, and especially when it comes across the departments, right? Everybody, or a lot of the facilities that I go into, they firmly believe that it's the job of sterile processing. Sterile processing is responsible for pretreatment. And when I was working on the vendor side, on the chemistry side, and going into hospitals and trying to work with them as far as getting a team process implemented across the departments and having an understanding of, it's not just sterile processing that is responsible for this. It is the entire hospital, especially anybody, the OR especially, because they're the ones that are touching the instruments and they need to have an adequate understanding. And so my question to you would be, do you have some examples of success stories on how you have implemented programs across a department or hospital departments, and how you've worked with other departments to get them to understand the importance of this process?
Yes. So as I said, we started this process with the OR, right? We developed a training course, so the OR, everybody in the OR has the same knowledge base. It isn't like you're dealing with a bunch of people that they know a little bit of this or a little bit of that. We've kind of created that. This is what our expectation is. We've shown them that, all of the organizations that we all belong to, so, AORN, AST, AMI, they all say the same thing. So where your organization, if you're a scrub tech, your organization is saying the same thing that my organization is saying, and kind of laid that out for the OR. I think the biggest thing that we've got out of it is that everybody now has that understanding of what the goal is, and what we've done to help bring that in front of everybody are those feedback forms. We've asked the staff to, hey, if you see an error or an issue, we need to make sure that we're reporting that now so we can get that out to the people that are actually doing that process, so we can get that fixed immediately, right? Same day. That's our goal, is same day processes. So if there was an issue made, that it's taken care of right then. The person that made, obviously we're not looking at blame, we're looking at process improvement. So we're not going back to that person and saying, you did this wrong, it's your fault, right? It's, hey, look, this is how we expect it to come over to us, and this is why, right? So we're laying that all out to them. And we've definitely seen an improvement in my facility over the past year since we've rolled that out. Once we rolled that out to the OR, we actually rolled that out house-wide to all of the ancillary departments that we take care of, labor and delivery, the wound care clinic, pain management, so that we actually rolled out another education. Obviously, it wasn't as in-depth as the OR one, but we've actually created a separate one for those ancillary departments that handle maybe 10, 20 instruments a day, you're saying, or anything like that. So they actually have the same knowledge base as us, and we can go back and say, hey, remember that presentation that we did? This is why we didn't meet that. So that's kind of how we rolled that out, and we've definitely seen improvements.
Awesome. Yeah, I mean, when I was doing in-service training and trying to help that process across departments, I would go in and I would actually have a cart, and I would go with the infection prevention manager from department to department with a tray of instruments. And it was not as in depth, but as you know, a lot of the departments don't have the time to get everybody together. So we would go to the departments and show them, how to adequately have your scissors open, how to stack your instruments, and then would just go through just a general display of how to pre-treat these instruments. And it was interesting because they started to just understand, like, okay, it actually has to be done at point of use. It can't wait. And so it was oftentimes it was on the kind of the beginnings of a Joint Commission visit, or they knew that it was coming. So definitely something that was focused on, and trying to help them through that process was a big focus on my side.
Right. Yeah. So one of the things that we did with some of the ancillary departments, obviously we met with the nursing education department, and we've actually used our in-house learning modules. So we created that training is in that learning module. So that way it's a yearly refresher for all of the staff. If you have a new staff come in, they actually have to do it when they do their orientation, but then, every year after that, they're seeing the same thing over and over. Right. And the only thing that I can stress the most is you have to get to a point where it's not looking to blame an individual as it is to fix the process. I mean, that's the biggest thing is when we talk about sterile processing and fixing processes, is most of the time it's not an issue with a person, it's an issue with a process. Right. And trying to create that across the organization is probably one of the most important things about any type of pretreatment program that you want to sustain.
Yep. Yeah, the team-oriented approach is very critical when it comes to that, for sure. So I got some questions from the audience here that we'll start motoring through. Have you found your chemical representatives to be generally helpful in educating the OR, or do they cause unhelpful complexity or confusion to the workflow?
I think there's a little bit of both. I mean, I think you have to use your chemical representative to get the correct information. I think a lot of times, sometimes people present of what they think they know, rather than getting actual facts and then presenting those. I think that's the important thing when you talk about when you have someone come in to do a presentation, making sure that they're presenting the information that you want out there. It can become more of a, my rep said this or my rep said that, rather than, this is exactly what that manufacturer says. Right.
Yeah. And I've seen good and bad on my side. I've seen misinformation, and I've seen just, this is what you need to use, and nothing behind it. So I think going back to what you talk about as far as processes are concerned, you need to make sure that you're presenting in the effect of saying, this is how it's going to help improve your processes. This is what it does. And, go from that standpoint when you're talking about a vendor. So would it be a good idea to have the techs and nurses go into the SPD and see the flow and why the pre-cleaning and soaking is important?
Well, I would say 100% yes on that. One of the things that we do at our facility is any new nurse that gets hired or is coming on during their orientation process, they actually spend 3 days in sterile processing. One whole day, so 1 8-hour day is spent in the decontamination room. So for that instrumentation coming over from the OR. So it's definitely important for them to see what goes on over in sterile processing.
Do you find challenges? One question would be, are you processing anything from offsite, from surgical centers or anything coming into the hospital?
We don't process anything offsite. We do have 3 different surgical suites in the hospital that are not all in the same place, but nothing from offsite.
Would you have some recommendations for, say, surgical centers that can't process on site and they have to ship their instruments into OR, or excuse me, an SPD at a larger facility?
I think obviously the important thing is make sure you're using the correct products. You're going to want to get a product that actually keeps those instruments moist for the amount of time that you're looking at. You know, a facility that does that here in Kansas City may be completely different than a facility that does that in LA, because it takes an hour and a half to drive it from one facility to another, right? Making sure that you have a product that's actually keeping that instrumentation moist for the time that you're going to be transporting it. You know, I would say the same way would be as if you're moving products around, someone needs to go to the originating place and give that base knowledge so everybody is on the same page.
Right. Yep. Great answer. What are your thoughts on picking a certain day of the week or month to conduct point of use audits? Is that successful, or must these audits be done on every tray every time?
Well, I think in the beginning, right, you're going to need to be more proactive and probably do more trays. I would say picking days of the week to do it, very similar to preventative maintenance of instrumentation. When you pick specific days of the week to do your preventative maintenance, you tend to see just specific trays. So I think the same thing would happen with audits. You know, like our big ortho day is on Wednesday. So if we never did an audit on Wednesday, we would never audit any orthopedic cases. So I would say you would have to maybe pick a rolling audit to where it rolls through, so you're seeing all the different types of procedures that you're doing at your facility. So you're hitting every different kind.
Awesome. Yeah. Well, and to that point, here's a good follow-up question to that is, how do you keep audits and photos from feeling like it's, quote, a gotcha moment or more of a lessons learned? Is it an individual issue, but often a process issue?
Yeah, I think the biggest thing is how you approach that individual and talk about like what you see. You know, for instance that I have is we had a person that maybe didn't spray something that was in their tray, but everything else in that whole case cart was perfect, right? They had their trays stacked right. They had all their instrumentation back, but they didn't spray one tray that was in that cart. So when we went to talk to that person, they kind of felt like, well, I did everything right. And we kind of approached it as, you know, well, we just need to figure out what happened, why this one tray wasn't sprayed. And it turned out, obviously, that person left the room and got replaced, right? So it wasn't even that person, right? So it's that conversation and talking about, you know, why did that happen, rather than going to someone and saying, hey, you did this wrong. You need to fix this, right? It's hey, what happened during this procedure that we can help alleviate why this occurred.
Right. Yep. It's more of a, you know, one-to-one teamwork discussion as we've talked about previously. As far as improving the soaking and pre-treatment process in the OR, me personally, I have gone into ORs, you know, post-surgical after the patient has been wheeled out, obviously, and been in there to work with the nurse teams and help them with pre-treatment processes, immediately after the procedure. But do you have any other recommendations? I know there's oftentimes, you know, with a busy OR for sure, you've got these spray bottles that are being used constantly, and it can get a little rough on your hands. It's you're using a trigger. I know that there are some automated or processes and machines that you can use. Is there anything that you would help or you would suggest to help with the OR and flow between OR and SPD?
I mean, I think the biggest thing is just having that discussion, right? If you have an OR team that is having trouble with a pump bottle of spray, you know, and having that discussion and finding that out, right? So now you know that that's one of the issues why you're having trouble getting that pretreatment process up off the ground, maybe look for that product that you don't need to have that trigger. Having enough product, right? So your staff isn't running out of a product and then have to go and search for that product somewhere else. Having it close to them in that OR suite, all of those things, when you look at that process, usually fail because of the process. Usually it's not that person that says, hey, I just don't want to spray these instruments. You'll find that when you run into failures and problems, it's usually because of a reason. And having those discussions to find out what those reasons are and then resolving them is the important part.
Yeah, and I think also when you're talking chemistry and the use of bottles and stuff like that, you think of, there's the two different options in the market right now, right? There's the foams and there's the gels. And there's good and bad associated with both. The foams, of course, you can see that the instruments are adequately treated. And the gels, you can't always tell if the instruments are fully coated and treated and protected. And then sometimes there's the gels with, it causes a little bit of stickiness. Then there's the enzymatics and everything like that. Do you have any recommendations on what is best as far as the use of chemistry and the type of chemistry, whether it's gels or foams?
I think you have to find out what's right for your facility. And when I say that, I know everybody says that, that's what everybody wants to do, but, the water quality at your facility, depending on, that all plays a part in how easily rinsed a gel or a foam comes off. I think finding the correct chemical for your facility is important. It isn't just, hey, just pick the first one and try that one. You need to really set out a process and a trial form where you're trying several different chemicals, several different, whether it's foam or gel, whether it's pump or aerosol, products, so you can find what you feel works best for your facility.
Good answer. Yeah, and then there's also the disconnect too with the understanding of, there's the enzymatics and the non-enzymatics, right? And which one works better? And I think sometimes it's to the level of what you're dealing with as far as surgical load, the type of surgeries that you're dealing with, and obviously the instrumentation. Do you have a preference on your side with it, whether it be enzymatics or just non-enzymatics, straight detergents? Do you have a personal preference?
Are you talking about with detergent? Is that what you're talking about?
Yeah, just with the pre-treatment spray itself, because
so we use a gel aerosol can without enzymatic. It's just a wetting agent. And we feel like as long as we can keep those instruments moist until we process them, we're better off. Now, obviously my facility is different than most facilities. I'm right next to the OR. So when the instruments leave an OR room, they get wheeled directly into the decontamination room. So, it's less than a minute from the time that they leave the OR room until the time that they're in the decontamination room. So, again, obviously this being related to the facility that you're in, it may take a half an hour for those instruments once they leave the OR room to get to your decontamination area. It really depends on what your situation is and what would work best for you. We definitely like the wetting agent because that just keeps those instruments moist until we get them and they get into the sink where we're actually hand washing.
Yeah, I think I've seen some facilities like yours that it's quick pass through and it's into the SPD and into the sinks pretty quickly. And then there's others where there's that prolonged soaking time that sometimes the instruments can sit up to 6 to 12 hours sometimes. So
right.
Yeah, that's a good point as far as the type of chemistry. Do you encourage collaborative policy development and alignment between OR and SPD, even if, infection prevention? And if so, how do you lead the policy update so that both groups feel represented?
Yeah, so we definitely have a, group that we have that meets anytime we were writing policies, this one being the same way, the pretreatment policy, it was involved with the OR and infection control were all involved in this process, and we were meeting and designing how we wanted this plan to roll out. It's definitely a collaborative effort. You're not going to get buy-in without having that collaborative effort. One of the things that we see is, when we do actually go to educate or talk about an issue, there's always a person from each team, right? There's always a person from sterile processing, and there's always a person from the OR when we're talking to individuals, whether it's an SPD staff or an OR staff. We kind of group together and we talk about it. That way, if there's questions that come from the OR that maybe the OR needs to answer, or, we're there as a team when we're having those discussions.
Yeah, collaboration is incredibly important, even when it comes to involving the infection prevention managers and quality sometimes as well. So let's see here. This is something that you brought up. So why do you not recommend spraying or pre-treating inside the cart? Joint Commission suggested that the instrument should be sprayed inside the containers and in this case cart, and that may be due to a recent facility visit. So
one of the things that we were seeing when they were being sprayed in the carts is we were having a abundance of pre-treatment dripping down off of the instruments into the carts and causing some issues on cleaning the carts. We would much rather them see them being sprayed on the back table when they're spraying. So anything that kind of drips down is dripping onto their towels on the back table.
Yeah, and it can also be a slip risk, right? If that pre-treatment product is coming out of the case carts and onto the floor, that can be another safety hazard as well. So, good points. So let's see. If staff does not pre-clean their instruments before sending them to SPD, what follow-up measures should be taken?
Well, I think there has to be a discussion. I think the first thing is you roll out your education and you make sure that everybody is aware of what the expectation is, right? And then at that point is when you would, when you get a tray back that maybe isn't processed correctly, at our facility, we approach it as we get somebody from the OR, whether it be the director or the service line supervisors that we have, and we approach those individuals and to have a discussion about like why that didn't happen. What was the barrier that caused that from happening? Is how we approach every single issue that we have. In the beginning, it's cumbersome. It's going to be a lot. It's going to be, you're going to have to stop what you're doing to go and talk to somebody. That happens. But kind of the way that I've taught it here is the more that we do now is the less that we'll have to do later.
Right. Yeah. Great philosophy for sure. So you defined gross soil as no visible blood. Is this realistic? And can you clarify what is gross soil versus soil in this context? Yeah. And why do professional guidelines call out gross soil versus soil in general? Great question.
Yes. It's the, $2 million question for sterile processing. We are told that gross soil needs to be removed from instrumentation. And like I said earlier, when you talk about gross soil, what one person considers gross soil, somebody else can consider, that's not that bad. So I think it has to be based on facility. What I found is that there is nobody out there that will give you that definition. We feel like at our facility that most of the bioburden needs to be removed from the instrumentation, and that's our expectation. We do not want to see a tray come back where you have instruments that are covered in blood. Are they going to be able to remove all the blood? I don't know that that's possible or even realistic, right, without actually giving them a brush and a sink in every single OR suite. And that's obviously not something that we want to do. It's a difficult standard to meet, is all I can say. You're going to have different surveyors that come in and have different definitions of gross soil. It's definitely one of the areas where it becomes difficult to meet. I don't have the exact answer, right? The definition that I gave you was the definition that I found, and that's kind of where we stand at our facility.
Great. How would you suggest compliance with a department like L&D, who don't always get the same training as the OR technicians? How can they bring their instruments back to SPD quicker?
I think the biggest thing is having somebody from your SPD giving that education. I think, when you rely on L&D educating their staff on the processes that SPD expects or does, that's where you see that maybe that disconnect. Whereas if you say you have that somebody from sterile processing doing that education in L&D, you get better traction with it.
Right. So this question here, I think, goes towards your emphasis on process, but and this is from obviously one of our audience members. But why does OR tend to be so confrontational when asked to follow guidelines and perform point of use bioburden removal?
Yes. So the only thing that I can say to this is, the OR has an expectation that's applied to them as well. And if they're not kind of given the proper resources to meet that, that's where it becomes, well, you keep asking me to do more with less, right? We're asking them to reduce their turnover times. Their turnover time might be 15 minutes, and we're saying, hey, this needs to get down to 12. But we also need you to make sure you're pre-treating your instrumentation. Well, how can I do that, right? Having that educator in the OR that can teach that staff how they can accomplish all of the goals along the lines is the important thing. If you just go up to somebody and say, hey, I just need you to do more. I need you to do it quicker and faster. You're going to get that pushback. But if you say, hey, look, we've figured out that if you do it this way, we can still meet our turnover times and still accomplish the pre-treatment of the instrumentation.
Great. Let's see. So how do you deal with, say, the OR staff or nurse thinking that saline is okay for soaking instruments? Yeah, this is a big one that I've seen. So
yeah,
it's
all about that education piece of it, right? Making sure that staff understand that saline isn't good for instrumentation. Some of the things that I've done in the past is demonstrate, right? Give a demonstration, find an instrument that is bad, and stick it in saline so the OR staff can see it, right? Maybe it's a glass jar of saline in the OR lounge, and you stick an instrument in it, and they can see what happens to it every day, right? So it's there in front of them. Slides in a PowerPoint, like this is what happens when we use saline on instrumentation. It is up to what we've learned, what I've learned, at least in the past 29 years in sterile processing. It is up to us. If we want people to be educated in the OR, it is up to us to educate them on what our expectations are.
Yep, and at a even keel, and as you said, as process related as possible, and not pointing fingers for sure. How long? So, we touched on the fact that you've got quick access from the OR to SPD, but how long should it take, ideally, from pre-cleaning to manual cleaning at the sink?
Obviously, you're going to get different reactions from IFUs, right? So every IFU for certain things have, how long that should take, in the process. But in general, I would say, if you're looking at more than an hour from pre-treatment, right, you're probably over that period. I always tell people, at our facility, I don't like things sitting more than 30 minutes, right? We're right next to the OR. We shouldn't have that sitting there like that. But if you're further away, maybe yours is an hour. But I think once you reach that 60-minute point, you're at a point, where you're going to be running into problems.
Yeah, and that goes to the coined term, the golden hour, right? Especially when you're talking scopes and lumened instruments, especially those are when you can't see what's inside, and making sure that you're getting those flushed out and at least getting some type of material inside those channels, I think is real critical, because the more time that you give any of that those soils to dry, the more problems arise, as you pointed out with the bioburden. And, as far as scopes are concerned, I think they continue to be an evolution, right? The use is growing. Robotics is another big technology. What are your pre-treatment processes? There's the point of use, again, with scopes, and we touched a lot on the instruments and sprays and everything, but when you're talking scopes, what are your recommendations as soon as, the scope is done being used, the patient is wheeled out of the room? There's a lot of sponge treatments out there with, enzymatics, detergents, and do you have a process surrounding the scopes?
Yeah, so the process that we have here is we've actually designed a flip chart that actually sits on the side of the tower for the scope, just because we were running into, I forgot how to do this or I forgot how to do that, because there was so much changing in the OR. We didn't have dedicated people that were using those scopes. So we designed a wipeable, waterproof flip chart that actually says step by step, like, this is, you do this, do this, do this, do this next. I'm a big proponent of, I don't ask the staff in my department to know everything, but I ask the staff in my department to know where to get the answers to everything, right? So if you base everything you do off of memory, you're going to end up missing steps or leaving stuff out. But if you have the ability to look at what you're doing at that time and gather that knowledge, you're going to find better outcomes.
Yeah, for sure. And I think anybody who's watched this conference today, we've touched on the fact that the standards and guidelines are in 200 pages. There are so many processes that our techs and managers, directors have to follow that it's impossible to expect them to memorize and know everything, every single step of the way. So like you said, having the resources available, and that includes involving the vendors. The vendors also need to be a good resource. They need to be available for IFUs and have a full knowledge of the IFUs, and just be able to disseminate the information that's needed to help out the hospitals and SPD in general. Well, I think we've got time for maybe one more question here. So this goes in terms of looking ahead, and in terms of chemicals or technologies in the future, where do you see opportunities still out there to innovate or around point of use treatment?
I think there's definitely some opportunities when you look at the complexity of instrumentation that we have, right? When you brought up the robotic instrumentation, and we look at that instrument and we say, all right, well, if I just spray this stuff all over the outside of it, is it really doing anything to the internal pieces of that? Or are we going to start using some type of irrigation system, right, in the OR to pre-treat those instrumentations before they come to us? And I think we're going to see a lot more of advances in that aspect of those more chemical or more complex instruments, seeing more robust pre-treatment of those than what we're seeing right now with just spraying on the outside of them.
Right. And yeah, because as you mentioned, and as we talked about, you can't really get anything inside those channels by just spraying it on the outside. So
right.
I'm sure there's going to be some more movement towards figuring out how to adequately irrigate those channels for sure. Well, I think we are at time, and I really appreciate the time and all of your background and information and expertise on this important topic. I learned a lot from you, just, from my experience on the vendor side and working in tandem with sterile processing and OR and multiple hospital departments. So really appreciate your insight, William, and thanks for joining us, for sure.
All right. Thank you very much, Brett.
Yeah.
Everybody have a great day.
Yeah. So if any of you have any questions and we weren't able to get to you, you can connect with William via email. And just a reminder, there'll be a short 15-minute break before our final session. So please hop in and jump and join us for that session. It's going to be an interesting panel discussion. Hank Balch is going to join us once again, and we will see you there shortly. Thanks again, everybody.